Thank you, Binay. Dr. Venugopal, will invite you back up to the podium to talk about the higher grade lymphomas at this point. And then after this presentation, we'll have a chance to ask questions of these presenters.
Thank you. So Dr. Shah has given a very good background for my talk. You heard about low-grade lymphomas, and now I will talk about the other type of non-Hodgkin's lymphoma, the so-called aggressive lymphoma. Among the aggressive lymphoma, diffuse large B-cell lymphoma is the commonest, as you can see from this slide. This is the diffuse large B-cell lymphoma component of the pie, and the closest is follicular lymphoma, which you heard from Dr. Shah after diffuse large B-cell lymphoma. So, as the name indicates, this disease is comprised of large cells, unlike low-grade lymphoma where there are small cells. And it's a disease which is curable. I think that's the most important point. If you treat it aggressively up front, these patients are salvageable, and with the modern chemotherapy regimen, frontline treatment, 60-65% at least, we should be able to cure when the diffuse large B-cell lymphoma is with standard risk factors. So just a few words about diffuse large B-cell lymphoma before I talk about some of the new developments in this area. There are some variants of this disease. For example, the so-called primary mediastinal large B-cell lymphoma. It's also a large B-cell lymphoma, but it has certain biological, prognostic, and therapeutic implications. Typically, they present with large mediastinal mass, and you give chemotherapy, and they are highly curable. Previously, we used to consolidate everybody with radiation, but now that is controversial because many a time chemotherapy itself is enough. And the aim of research now is to reduce the toxicity because the cure rate is already high. There are other types like primary effusion lymphoma. These patients just come with the effusions, ascites, pleural effusion, pericardial effusion, no lymph node enlargement, and you find the lymphoma cells in the fluid, which is usually seen in the setting of HIV, but you can have non-HIV primary effusion lymphoma also. Intravascular lymphoma is something very interesting because it is one that is very, very difficult to diagnose. In this disease, it's the same lymphoma cells, but they grew inside the blood vessels. And they don't come with enlarged lymph nodes or spleen like a typical garden variety of lymphoma patient. So because these lymphoma cells grow through the vessels, it is very often delayed. The diagnosis is delayed. They may come with symptoms and signs of vascular insufficiency. Sometimes even repeat biopsies, we may miss the diagnosis. So it used to be called one of the biggest masqueraders in medicine where diagnosis may be delayed. In fact, a good number of these patients, the diagnosis is established at autopsy. These are some of the other types. I would not probably spend much time. Prognosis, the standard clinical tool we have is the IPI, or International Prognostic Index, where we look at these 5 factors and put them into one of these risk categories: low, low intermediate, high intermediate, or high risk category. And you can see if the 5-year survival is quite different from 73 to 26% depending on the category. So this is a very good tool to talk to the patient about prognosis when you first meet with them after the workup is completed before starting treatment. And this is a graphic representation of the same, indicating that the survival is much better based on the risk factors, the lower prognostic features. So there are other more recent approaches identifying the prognostic categories. One, of course, is the DNA microarray, based on which you can put these diffuse large B-cell lymphoma into various categories. One is the so-called germinal center type and the non-germinal center type. And again, clearly you can see that germinal center patients, as patients with germinal center diffuse large B-cell lymphoma, they do much better compared to patients with activated B-cell or the non-germinal center. Not only prognostic but also therapeutic implications. There are agents which can affect the pathways that are involved in patients with activated B-cell. For example, the NF-kappa B pathway is very active in these patients with activated B-cell lymphoma, and we can use agents there which specifically affect the pathway to improve their outcome. So what are the treatment options of diffuse large B-cell lymphoma? I will, in the next few slides, what I'm going to do is to tell you what is standard of care, just as Dr. Shah told you what is standard of care in localized low-grade lymphoma and advanced low-grade lymphoma. So I'll talk to you about what is the standard of care for a localized diffuse large B-cell lymphoma and what is the standard of care for advanced diffuse large B-cell lymphoma, and I will show you the studies based on which these standard of care is established, and then I will show you how people are trying to improve upon the results of what is standard of care. So if a patient has localized large B-cell lymphoma or aggressive lymphoma, you give an abbreviated course of chemotherapy, 3 or 4 cycles. Now it is R-CHOP with radiation. So that is standard of care. And how did we get there? Well, there are several trials that looked at it, and the sum and substance is you can certainly reduce the amount of anthracycline in localized disease by stopping after 3 or 4 cycles and consolidating with radiation. But in the randomized study by Tom Miller, when they looked at it, the patients who received abbreviated chemo and a full dose of 6 cycles of chemo, there was some advantage until 7-8 years for the group who got radiation, but after that the curves were very similar. So in other words, the long-term outcome is very similar whether you give abbreviated chemo with radiation or a full dose of chemotherapy. So nowadays we give the patient both options. And many a time, the ultimate decision is based on, for example, if the patient has borderline cardiac function, you don't want to push so much anthracycline. You may stop after 3 or 4 cycles and consolidate. Or if the disease is in a location where radiation can bring more side effects, patient may opt to continue and complete the 6 cycles. So both of them are appropriate. Advanced stage disease, standard of care now is R-CHOP. 6 to 8 cycles. In Europe, most of the trials have used 8 cycles, but in the United States, we mostly use 6 cycles of treatment. So how did we get there? How did we get to R-CHOP as a standard of care? So, okay, for localized disease, there is data on Rituximab also. And I think I will skip that. Okay, so this is the so-called National High Priority Lymphoma Study, which brought CHOP as standard of care in large cell lymphoma. Before that, there were a lot of phase 2 studies showing that these fancy, sounding names, these chemotherapy regimens have much higher outcomes in terms of response rates and progression-free survival. In fact, in a randomized trial like this, the PI was even criticized for randomizing patients to CHOP because it was supposed to be inferior at that time. But the study proved that they are all equally efficient, with CHOP being much less in terms of side effects. So that's how CHOP became standard of care. And this was some time back, as you can see here, the New England Journal of Medicine publication. It went on until early 2000 when Rituximab showed up in diffuse large B-cell lymphoma, and that was the study, the so-called JELA study, French study published by Coffier, where patients with untreated diffuse large B-cell lymphoma were randomized to receive standard CHOP at that time, which was standard, or CHOP with Rituximab. and that showed that whether you look at the progression-free survival or the overall survival, there was statistically significant superiority of rituximab combination over CHOP. That's how R-CHOP became standard of care for diffuse large B-cell lymphoma advanced stage. Now, if you look at that group, this JELA study, the initial JELA study is for elderly patients. And what about younger patients? Is it similar? Is Rituxan similarly effective? Yes. So this is the study, the MINT study, that showed that even in patients younger than 60 years, the addition of rituximab made significant difference. So that is why R-CHOP is standard of care for younger and older patients alike. And then came the question of maintenance. You heard from Dr. Shah that in low-grade lymphoma, in follicular lymphoma, if you give chemotherapy, chemoimmunotherapy, or rituximab alone, and then maintain them with rituximab for 2 years, you can certainly increase the progression-free survival. So is that applicable in diffuse large B-cell lymphoma? That was the next question. This was a trial that was done in the United States, which answered that question. And as you know, one of the problems why we don't do a good job here in the United States with clinical trial is the design of our trials. Our trials are complicated. As you can see here, 2 randomization, again, stratifying patients based on different categories. Unlike the GILA study you saw, I asked Dr. Kafieh, why is it that you accrue patients so quickly? Well, we only asked one question. That was his answer, which is the truth. Here we try to answer so many questions that we end up having small number of patients without any power to say, yes, this works. But even though that is the problem with this trial really answered one question. That is there a role of maintenance rituximab in patients with diffuse large B-cell lymphoma who received R-CHOP? The answer was no. So in other words, the patients who received rituximab with CHOP, when they were randomized to maintenance rituximab, there was no difference between the outcome of those patients compared to patients who were on observation. So the study also showed in diffuse large B-cell lymphoma, if you give Rituxan in the beginning or at the end, the outcome is the same. In other words, if the patient receives just CHOP, which doesn't happen nowadays because R-CHOP is standard, you can still get the same outcome by adding Rituximab later on. So, simple answer, Rituximab maintenance has no role in patients with diffuse large B-cell lymphoma who were treated with R-CHOP. So now comes the question, is R-CHOP the only thing, or can we make it even better? So over the years, people have done in many ways trying to improve the R-CHOP. One, dose dense. So in other words, you can have dose dense or dose intensity. We are giving R-CHOP every 3 weeks. Why? Because the 3rd week we need for the patient's blood counts to recover. So why not give it every 2 weeks? Because the 3rd week is allowing the patient's white cell count to recover, but it also allows the lymphoma cells to recover or regrowth. So that's why the so-called dose-dense treatment, R-CHOP, 14-day, 2-weekly R-CHOP. Believe me, there have been a lot of trials, including in our institution and internationally, which really didn't pan out to be a big success. In fact, there has been problems identified because the steroids are given so close together. So many of the trials which we did, Memorial Sloan Kettering did, plus European, all of them identified patients developing even PCP, which, as you know, in CHOP, typically you don't find PCP pneumonia as a complication, but these patients did develop in many of the studies. So the point is, dose-dense chemotherapy or R-CHOP every 14 days has not been proven to be standard of care, even though in Germany people still use it. There has been other attempts. Dose intensity. Can we increase the intensity of CHOP And anybody who has heard Dr. Wyndham Wilson from NCI talking, this is his passion, the so-called ECOG regimen. All his life he has been doing that, and it works in every disease. I know it is being recorded. Okay, so that's what I hear every time. Anyway, so ECOG, it is true, ECOG works better than CHOP in certain situations, but we don't have randomized data to say, yes, this is better than our CHOP. The other way to enhance the outcome of R-CHOP is to see if we can consolidate with something else. For example, you give R-CHOP, put them into remission, and consolidate a patient with, for example, an autologous stem cell transplant, already proven that it is not going to contribute anything more. Second, can we give radioimmunotherapy? Dr. Shah showed you that radioimmunotherapy, where radioisotope is conjugated with monoclonal antibody and you give it IV, is standard of care in low-grade lymphoma, and it is FDA approved for transformed lymphoma. But in the setting of diffuse large B-cell lymphoma, it has not been proven to be very effective. And this is one of our own clinical trials in our institution, one of the first trials where we showed in 20 patients that when you give Zevalin, Zevalin is a radioimmunotherapy agent, after R-CHOP, you can convert even the partial remissions, majority of them, into complete remissions. But long term, it didn't pan out to be very successful. Other strategies for improving on R-CHOP, we can add bortezomib or Velcade, as you know, is a drug which is FDA approved for myeloma, mantle cell lymphoma. Bortezomib inhibits NF-kappa pathways. And as I explained before, the subset of diffuse large B-cell lymphoma patients, so-called non-germinal central, they depend a lot on NF-kappa B pathway. And there is very well-published data on bortezomib making a difference in those patients. But again, randomized studies did not prove that, so that didn't work out well. Brentuximab vedotin, which is a anti-CD30 monoclonal antibody, which is approved for Hodgkin's lymphoma and anaplastic large cell lymphoma, is being tried in a large randomized study in R-CHOP combination. And of course, the BTK and the PI3 kinase inhibitors are the new kids on the block, and of course, everybody is adding these agents to chemotherapy regimen. So those trials are going on. So the last few slides, I'm going to show two presentations from the last American Society of Hematology meeting, which were, I think, to me, the most interesting in diffuse large B-cell lymphoma from that meeting. One is a subset analysis of the so-called CORAL study. CORAL stands for Collaborative Trial in Relapsed Aggressive Lymphoma, done by LYSA. LYSA is the new name for GILA, the French group which established many standards of care in lymphoma, including the R-CHOP. So the CORAL study was looking at patients who had relapsed refractory diffuse large B-cell lymphoma. As you know, the standard of care for diffuse large B-cell lymphoma when they relapse or they don't respond to standard initial treatment is giving them a second-line chemotherapy, putting them in remission, and then taking them to an autologous stem cell transplant, or rarely allo. So that still cures patients. I would say 50%, I'm sure Dr. Randelli will say more than 50% he can cure. But certainly, you can cure patients who relapse after standard treatment in diffuse large B-cell lymphoma. So these patients, what they did was they randomized to receive the second line. There are different second line chemotherapy regimens for patients who come back with disease after R-CHOP. ICE, DHAP, ESHAP, those are all regimens which have not been compared in a randomized manner. So we all use depending on our comfort level, experience. So here, in this trial, they randomized patients to receive RICE or RDHAP. And patients who had a response went on to receive autologous stem cell transplant, and then they were randomized to receive maintenance versus observation. So that was the original CORAL regimen. So what this analysis looked at is patients who did not respond to the initial treatment. It says fail. Actually, I think it's not the patients who fail, it's the providers who fail. But in any case, so patients who did not achieve remission, they looked at them, and what they did was, there was about 145 of them, and they reinduced with a third line. So you had the R-CHOP, the second line was RISE or RDHAP, and this is the third line, and third line still gave about 43% response. So they looked at patients who received RISE and did not get into remission. They received DHAP as a third line. Similarly, patients who did not respond to RDHAP received RISE as the third line. In each of them, you can see about 42 to 45% of them did respond to the third line. And then they went on to receive an autologous stem cell transplant. And again, there was a difference between patients who received transplant versus no transplant. So if you look at in different ways, overall survival according to patients who had transplant versus no transplant, this is yes transplants, you can see that the median overall survival is 11 months compared to 5 months without transplant. And this is multivariate analysis, it is across all variants. And if you look at the IPI, usually IPI is reserved for upfront, but even if you look at the International Prognostic Index risk factor at the time of relapse, the patients who had lower risk factors, 0 to 2, they did better. Not a surprise. Again, according to the third line response, to third line patients who responded did very well compared to patients who did not. I think the point of this trial was that even if the patient did not respond to second line, you can still salvage them with a third line. And if they respond to the third line, you can still take them to transplant, and a subset of them will still have long-term remission. That's the point of this abstract, which to me was interesting, because once patients do not respond to R-CHOP and a second line, usually the prognosis is considered to be very poor. The last study I want to focus on is the presentation in the ASH on this drug, Rituximab. As you know, it's a monoclonal antibody which targets CD30. CD30 is typically expressed in Hodgkin's lymphoma and anaplastic large cell lymphoma. There is a subset of diffuse large B-cell lymphoma that also express CD30. So this was presented by Dr. Bartlett from WashU, and the standard dose of Brentuximab or Adcertis, as you can see here, was given, and these are patients who already had at least one previous treatment, and as you can see that the overall response rate was about 40% with 16% complete responses. And this is one of those fashionable waterfall plots. As you can see, majority of the patients did have some responses. There's a few who progress. Every time you see a bar hanging down, that means there is a reduction in the tumor. So the conclusion from the study was the patients had very promising anti-tumor effect in about 42% of the patients. We saw that. Another very interesting observation in this study is this, that is, as you know, we talked about targeted treatment. Targeted treatment, Dr. Shah even talked about missiles being used for targeting enemies. So you need a target, right? I mean, you need a target. You have to identify the target. So Rituximab works in patients with the CD20 positive tumor, because that's a tumor, that's the target. But over and again, we have found that even if we can't demonstrate that the target in certain tumors, these drugs still work. And the philosophy that was always put together is that you don't need many epitopes of the antigen for the therapeutic antibody to bind. The diagnostic antibody needs more antigens. So it may appear negative, but you may still get a response. And It has been shown repeatedly with targeted treatment. This is the latest example. See, patients who had even CD30 negative expression had responded to this monoclonal antibody. So I think the point I'm trying to say is we should not be giving up just because the antigen is not expressed, although practically that could be a problem, right? I mean, you need CD30 positivity to get the drug approved by the insurance company, of course. Okay, so I think I'm going to stop it here. And as I mentioned before, this trial, the trial where R-CHOP combined with Brentuximab in place of the vincristine, because as you know, Brentuximab, one of the major problems is neuropathy. So this trial is rapidly enrolling, and that should tell us the answer to the question whether R-CHOP with Brentuximab is superior to R-CHOP with vincristine. I think I will stop it here, and I'll be happy to answer questions. Is it together? Thank you.